Hello, everyone, and welcome to MedCity Invest Digital Health. I'm so glad that all of you could join us. I wanted to begin by sharing a few slides that'll help people understand a little bit more about MedCity News and what we do. So I am Arundhati Parmar. I'm the editor-in-chief of MedCity News. The company was founded in late 2008 to cover innovation in healthcare. We are a national publication. We do have some folks from international locations that read us too, but we're largely a national publication drawing nearly 2 million page views and 500K unique page views monthly. We cover biopharma, digital health, medical devices, diagnostics, as well as hospitals and payers in the context of the industry's overall transformation. Needless to say, we've been covering COVID-19 very, very closely. We also host conferences focusing on investment, population health, precision medicine, digital health, and patient engagement. We accept contributed content through a program called MedCity Influencers, so you can email me if you're interested in writing for us. We also have a program called MedCitizens. It's a membership-based program for startups with editorial and event benefits. And the contact for that is Stephanie Baum, and her email address will be placed in the chat for you all to see. We also do a podcast called Pivot Podcast. We launched it in, I believe it was April now, it's so long ago. But we've interviewed really interesting people, including Zeke Emanuel. So I urge you all to go to the website and click on the Pivot Podcast link. That'll also be placed in the chat. I also accept ideas for who my next guest should be. So if you feel strongly about someone who should be on the podcast, please email me and let me know. So I wanted to say a big thank you to all our sponsors, without whom this event it would be really hard to do. Fredrickson and Byron, Unity Point Health Ventures, and Deloitte. And of course, our partner for a very long time is Medical Alley Association. They've been with us for, I think this is the third year we're doing the program together. 2 years we've done it in person. This year we're doing it virtually. We hope to be back in Minneapolis next year. But for more about Medical Alley, I wanted to turn it over to Shay. Shay Mandel, President and CEO of the Medical Alley Association. Go ahead, Shay.
Well, thank you, Arundhati. Good morning or good afternoon, depending on where you're joining us from. As Arundhati said, we are very excited and proud to have had the opportunity to work with MedCity News now in our third year to bring you Invest Digital Health. As Arundhati said, I'm Shay Mandel. I have the honor every day of serving as the President and CEO of the Medical Alley Association. And for those of you joining, welcome to Minnesota's Medical Alley, the global epicenter of health, innovation, and care. We're all experiencing some pretty interesting times, and we think we've got a program set up that will really leverage what's happening. Very insightful. Our MedCity partners always put together a great group of content with us. And so we're excited both about the changes we're seeing in healthcare, but also what we think are the great opportunities. So we're all dealing with COVID-19. It has changed the face of healthcare almost overnight. And a lot of things that innovative companies have been working on prior to COVID-19 are really seeing acceleration in this marketplace. Arundhati did a commercial for the MedCity content. I'll mention for all of you, Medical Alley's also shifted to a significant amount of online content. You can find our Bringing the Future Forward series, where we're tackling these larger issues, as well as our What Now, What Next resource-based webinar series, as well as our podcasts. And you can find that wherever you listen to your podcasts. I mentioned we believe this is a time of great health transformation. Our organization represents every sector of healthcare, just as MedCity covers them. So we have providers and payers, digital health companies, biotech, pharma, and medtech, of course, here in Minnesota. And we've seen an opportunity for quite some time, and think COVID-19 creates more opportunities to really bring those sectors together. And so a year and a half ago, we launched the umbrella that we call the Healthcare Transformation Initiative. And we've been working with our members to improve our early stage ecosystem, we've been looking at pilot projects and opportunities to really demonstrate the value of digital health in particular. So we're very excited to be a part of transforming health through tech, and hope you really enjoy this week of content. As always, we look forward to seeing you in Minnesota next year. But for this year, we'll do it virtually, we'll do it well, and we just appreciate your support, both for our members, as well as the sponsors of this event and everyone attending across the country. So Arundhati, thank you. Looking forward to the content.
Thank you very much, Shay. And I know journalists are supposed to be objective and neutral, but I have to say that my association with Medical Alley actually predates Shay joining as president and CEO. And the association has always been very helpful in trying to paint a sort of accurate picture of what's happening in terms of innovation in healthcare in Minnesota. And what has always struck me was, even though the state's history is very much in medical devices, Shay and the Medical Alley Association have made big inroads in sort of highlighting tech innovation that happens along with traditional medical devices. And certainly some of those traditional device companies are embracing tech and digital in a way, in a way that we've not seen before. So thank you again, Shay, for being a partner with us in this endeavor. And we'll move on. So I'm very, very delighted to welcome two top women executives and women physician executives in our midst. We have Dr. Genevieve Melton-Meaux. She is with Fairview Health Services, and Rita Khan. She's the first digital officer of Mayo Clinic, and we're going to be discussing how hospital innovation is changing amidst this COVID-19 pandemic. So Rita, as I mentioned, is the first chief digital officer at Mayo Clinic, which created this position to drive the health system's digital strategy and establishing Mayo Clinic's Center for Digital Health. Prior to joining Mayo in January of 2020, Rita was SVP of Consumer Digital at UHC, United Healthcare, where she directed enterprise-level digital strategy. She also has 20 years of experience in e-commerce and held various positions at Digital River, Best Buy, and Target. She has a bachelor's degree from Tufts University and an MBA from the University of St. Thomas. Welcome, Rita. Next, we have Genevieve Melton-Meaux. She is the Chief Analytics and Care Innovation Officer at Fairview Health Services. She's also a professor of surgery and core faculty at the Institute of Informatics at the University of Minnesota. She's a practicing colorectal cancer surgeon, and leads Fairview's transformation efforts to be a data-driven organization. In transforming Fairview's care capabilities for population health, care variation reduction, and precision medicine, she has developed the organization's optimal care program. So welcome to you both. I wanted to first start with Rita. She has a few slides to share about how technology is being used in Mayo Clinic today and what the future looks like. So Rita, take it away from here.
Thank you, Arundhati. Appreciate the introduction. I just want to give some context in which I entered care delivery. So I joined Mayo Clinic back in February. And as I was joining the organization, it was immediately hit by the pandemic. And so it's been a really interesting journey, and I've had the privilege of seeing how Mayo Clinic has come together to solve this problem. What's really interesting about Mayo Clinic is just the commitment to patient care and thinking about the future, and has a history of innovation. So when I joined the organization, there was a tremendous amount of solutions in the digital care space that were already pre-built out. Now, as you can imagine, this pandemic has really driven adoption for both patients and physicians. One of the things that I think was interesting during this time frame is how we were able to leverage all of the tools that we had to make them accessible and scalable during this time. So I'm going to walk through some of the things that we put in place over the first, it looks like the slides are a little bit not displaying, so I don't know if it's part of the tool that we're using. But I'm just going to walk through a few of the things that we focused on. So just over the past few months, we've made over 3,000 large and small changes to our EHR to help guide COVID-19 patients. We also have our online self-assessment tools that we created to make sure that our patients could screen from at home so that they didn't come to campus and expose others. And it also helped us to conserve our PPE. We also launched a COVID-19 app providing local data alongside trusted guidance accessible from our newsroom, which we've seen a lot of adoption on. We also have our patient online services, which offers our patients a wide range of information, including medical records, clinical notes, radiology images, prescriptions, and others. But we saw our unique users jump to 150,000 since the beginning of that pandemic. So you can imagine adoption for digital tools is really growing. We also have our bedside tablet application before COVID-19, but became incredibly important for our patients to talk to their friends and family when we weren't able to allow visits in person. We also have enhanced video solutions that allowed hospital providers to interact with their COVID-19 positive patients if it wasn't necessary for them to have physical contact. And everybody has been talking about video appointments. Of course, we saw, our video appointments skyrocket in this time frame. So before the pandemic, we had about 40 patients a day using video appointments. Our highest peak day was 2,771 appointments through video. We also have a program for remote patient monitoring for non-hospitalized patients to provide 24/7 care and access to nurses and other medical experts. And this program became incredibly important to provide care from the comfort of one's home. And then finally, we had 2 pilots that we had launched in June and August, and we didn't slow down. We knew we needed to move forward and test out our program called Advanced Care at Home in partnership with the Mayo Clinic platform. And the goal was really to test new delivery models in Florida and Wisconsin. And this program really allows our patients with conditions previously managed in a hospital to have the option to transition to home setting to receive care, high quality virtual and in-person and recovery services. And we're working with Medically Home, a Boston-based technology-enabled services company, to deliver that. So the key learnings that we've experienced is obviously patient and staff safety as well as convenience is what drove the acceptance and adoption of these solutions. There was an evident need, and through this period, patient satisfaction remained high, and we were not expecting that. Previously, of course, everybody knows federal and state regulations as well as payer reimbursement restrictions have negatively impacted the willingness of patients and providers to engage in these types of services. And during this time, public health emergency declaration helped to drive the lifting and easement of some of these regulations, and it increased the type of digital services that would be reimbursed. So before COVID, our digital teams were focused on solutions that were standardized and scalable and positioned Mayo Clinic to respond quickly to support unique use cases that COVID-19 presented. We proved that we can move quickly, and we leveraged our agile product teams who possess the skills and experience to move fast, make effective decisions, and are empowered to reprioritize and pivot quickly. The pandemic has shifted our mindsets about how we can be effective, efficient, and quickly deliver. So pending any turnback of the regulations and payer reimbursement procedures, we expect to see a faster evolution of care delivery for the future. It's critical to deliver care in a more effective and affordable way. We also learned how important our existing vision and strategy for 2030 is around cure, connect, and transform. I think the challenge is, and the biggest learning that we have is, how do we do this tomorrow? We can't wait till 2030. And so that's what we've really focused on. And I think Shay said it really well. We can't lose this opportunity in this moment of transformation.
Rita, thank you very much. I think we were not able to see that first slide. Is it possible for you to share that one more time?
Oh, absolutely. Yeah. It was getting sticky.
Yes, that's the one.
Hopefully you can see it.
Yes, that's perfect. So before I go to Dr. Melton-Meaux, I wanted to ask you very briefly, if you could talk a little bit about why Mayo Clinic sort of felt the need to create this first Chief Digital Officer role. What are you doing that wasn't being done, I guess, before?
Yeah, that's a really good question. As I mentioned, Mayo Clinic's already been digital. We already had a Mayo Clinic app very early. We have lots of digital services that are already in place. But we have really ambitious goals to shape care delivery in the future. And we want to make sure that we are focused on not just providing solutions, but providing integrated solutions that are seamless, simple, and consumer-centric. And so to do that, we need a concerted effort, and that voice, that digital voice, needs to be in the room to translate the business strategy into a digital experience.
That makes sense. Thank you very much. You can stop sharing now, and then we'll turn it over to Dr. Melton-Meaux, who can take this away.
All right, I'm going to try to share my screen.
Yes, that looks good.
Okay, perfect. All right, so Arundhati asked us upfront to talk about what we did as COVID hit 6 months ago. It's hard to really believe it was 6 months ago. It's just been an extraordinary time for all of us. And it's really tested our teams and really society more broadly. And for us, I think outside of perhaps what I shared with you about the solutions that we brought together, it was really a time that brought us together in our parts, our people and teams and capabilities in a way I don't know if we've done before as a system. So it really brought us together as a system. When we got together and really formed, it was an incident command center for the entire system. That focus helped us to really drive forward really what I would say would be work that would typically take us several years to put together and to be able to do at such a large scale. So we quickly realized that we had to go virtual in many ways. So we've had a longstanding e-visit program with OnCare, which we expanded quite a bit. And then as well had an online symptom checker similar to what Rita was talking about. We also realized that urgent care, we needed to think about that also differently. So very quickly, in the very beginning, we actually shut down our urgent care, but very soon went to sort of a hybrid model where we looked immediately and triage patients, whether it was preference or appropriateness, to be able to do urgent care visits. The other thing to note, and this is a real testament to the work and our partnership with the University of Minnesota, is that we formed large evidence-based medicine teams. We have right now a total of, I think it's close to 25 guidelines that have the latest in evidence-based medicine. And this really, for the first time, I think, brought to really the forefront of awareness how important it is to have the best information to be able to care for these patients in the best appropriate way. And we created both a website that was provider-facing as well as materials for patients that would be understandable around various treatments. Similar to most systems, we had video platforms both for the inpatient and ambulatory setting. In the ambulatory setting, we actually found that we needed to have a backup, so we do have more than one at this point, just in case, and really had an eye towards, particularly around behavioral health, how can we avoid, where at all possible, inpatient behavioral health interactions, and where can we make the interactions virtual. So we've really pushed that to things like empath interactions as well as group visits, and as much as possible doing these on a virtual basis. Similar to what was just described as well, we have a remote patient monitoring program for patients that don't need to be hospitalized with COVID-19 symptoms. And then really getting over to the side of insights and care solutions, real-time risk scores, prognostic scores. We've also really pushed on the area of computable guidelines, including CPG on Fire, really trying to get that idea of interoperability. How do we share the learnings more broadly on a societal level? Another one that we're very proud of as well, and really was as well a great partnership with the University of Minnesota, is a deep learning algorithm that we now have live in our EMR. So what happens is when a chest x-ray is taken, it is processed through our PACS, immediately consumed. The algorithm gives us a risk score of whether or not this patient is COVID-19 positive. And its accuracy and sensitivity is better than RT-PCR, which is currently our standard of care. And what's exciting about that as well is that we are sharing that through Epic's App Orchard. So not fully interoperable, but will be available to many, many health systems. We're very proud of that. I think the other idea that really came out of this is this idea of hybrid care. Really, you know, what parts absolutely need to be potentially in person or delivered in a different way? How do we create other convenience care? And so, you know, even inpatient stays, we've had many more instances where once the patient is to a point where we can do home care and some remote monitoring, pushing it in that direction, as well as the idea of how much of my visit can I do virtually, and then maybe they just come in, a patient comes in and gets an immunization for a quick drive up part of their visit. The other theme that really came out was the idea of digital enablement around our health system. And we've had a systems operations center, and we've been using that around flow, and that has been in place for a couple of years, but this just heightened it to another level. The idea around resources, our ECMO machines, and the ability to have our patients be exactly at the right level of care and to match our staffing really in real time. We partnered with Cuventus on that set of work, and that also was a partnership with the MHA in having a statewide model. So the CMIOs throughout the state of Minnesota, for the most part, came together and really have been giving up-to-date information on a weekly basis, and this has been used at the state level to be able to say, you know, how do we do our planning around different aspects of COVID. We also launched an employee engagement app, as well as really for providers being able to bring expertise into primary care to link specialists much more affirmatively virtually on an asynchronous basis. And then finally, what was a lot of fun is we stood up a virtual care rotation. This brought medical students as well as residents from family medicine in to learn these skills. This did take a village. We partnered a lot with our vendor partners. I think I named most of them. Our e-consults, we use content for the AAMC. I mentioned the Smart on Fire, and then our remote patient monitoring program was through Get Well Loop in this case. Then I think the other part to sort of layer on top of this is just the yeoman's work and just the innovation that came out through the last 6 months. It, you know, never made me more proud to be part of the system. We stood up a hospital literally within close to 2 weeks that was a COVID exclusive hospital, really knowing how to care for these patients excellently. The outcomes have been unparalleled at this site at Bethesda. We have quite a number of very robust clinical trials around COVID in particular, and have been one of the leading centers in enrollment, in particular in the Midwest. And then finally, you know, just that idea of innovation. There's a picture at the bottom around something that was built that's basically a very low-cost ventilator in those days when we didn't know with our supply chain if we'd be able to get enough ventilators in. And so what's next? What have we learned? really it is that idea of, well, putting in a solution requires all the things around it to make it work. Our staff very much have embraced virtual, as have patients, but there are certain competencies that need to come along with that, and we do need to bring those together and catch everybody up on that. Also as well, all these experiences need to be experience-driven as we create them. They need to be seamless, and it needs to meld the digital, the virtual, and the in-person. And we need to do this safely and appropriately. I'm a colorectal surgeon. There are certain things that, no matter what, should not be done virtually, but quite a few things that definitely can be. As was mentioned, reimbursement is going to be a significant issue, and we really want to encourage the idea of the most appropriate, and there is a lot of fear about what will happen after the pandemic and how do we continue on this journey and not go back. And then I think as well, these models of care, there are still barriers, and really in most cases it does mean partnering very closely with payers to get some of these newer models reimbursed and to make them something that's feasible and scalable and financially viable. And then finally, I think, there is a significant concern about that third wave of morbidity, in surgery, as for instance, the backlog of patients and getting patients back for those, quote, elective procedures, many of which in reality are not that elective. Maybe they can wait a month and they're not life-threatening, but getting patients back in and helping them to know it's safe. We've been reaching out a lot, particularly around primary care as well, and we call that our Restore program. And then as well, just that recognition of health equity, that we do have a lot of disparity still in how to really have that lens to everything we do, and true recognition that that is part of who we are. And then finally, this was to us really the testament of that synergy that comes with bringing together a health system with academics. So really making evidence-based medicine, which we have with optimal care, but this is in just such a rigorous way. How do we, scale that more, continue with that type of lens within our system? And then how do we share that in an interoperable way and make that part of who we are on an ongoing basis? So with that, thank you.
Thank you very much, Genevieve. You can stop sharing your screen right now. So the thing that was common in both your slides was that reimbursement piece. And I'm wondering if you can expand a little bit on that, Genevieve. Are you expecting more payer-provider consolidation as a result of COVID-19 and this general fear that the reimbursement climate is going to become more difficult when we emerge from this crisis?
Well, I think that, the concern is overall we are being squeezed at a cost and payment level just broadly within healthcare. And, currently programs that are done that are virtually based, traditionally pay, a subset of funds on the dollar. Also, the definition of what was virtual before was significantly different than it is now. The idea of being reimbursed for a phone visit like that, almost at parity, was unheard of. So, it is not that there's an expectation of parity. There is simply, I think, an expectation that it can be viable. And that you can have a provider with, that is a provider with the expertise to be able to give these services in the way that is most appropriate and convenient for the patient.
That makes sense. Rita, let me jump over to you now. In terms of the fact that you also had the reimbursement piece, are you in active discussions with CMS or with private insurance companies explaining what the model can be? And are you seeing pushback? Where is the conversation right now?
Yeah, we're actively having conversations with both CMS and insurance providers, payers, because it's important. And I think everybody understands that care and models of care are changing. I think there's a huge push for ensuring we have better health outcomes and that we drive affordability. And I think, quite frankly, virtual care can play a significant role in that. And one of the things that we're focused on is how do we help tell that story? How do we look at the outcomes that we're seeing, any cost savings that we're seeing, and pulling that together to help educate and also help inform ourselves in how we can actually be more effective and efficient. And so there is work to be done. Obviously, during this COVID period, it's not necessarily steady state, but we're taking a look at this to understand the cost implications and share that with our partners.
The other thing I wanted to sort of briefly talk about is this explosion in e-visits and the fact that you're doing a lot of, during the pandemic, we were doing a lot of video visits. But a lot of the startups that I've spoken to that are developing these new primary care models are mentioning that, e-visits do not equal virtual care. So within Mayo and within your vision of how you see patient care move forward beyond the pandemic, how do you see virtual care evolve from video visits to something else?
Yeah, so I would say video visits is just such a narrow slice of what virtual care really is. And I mentioned briefly a lot of the solutions that we already have in place. I think what we're looking to do is make sure that we have the right care at the right time with the most effective touch point. And we should leverage everything at our fingertips in terms of technology to do that. We're at an important point, I think, in healthcare. And I can't underscore this enough, I keep bringing this up, but affordability is incredibly important in driving health outcomes and reaching more people with more effective solutions. And so I think of virtual care in the most broadest sense. And I actually don't think of it as only technology driven. Even in care, in-person care is driven by technology and is a component of a holistic care solution.
I guess I was hoping for a little more of a specific example. I mean, when we talked about technology in the hospital, everyone, mentioned EHR, and the EHR, I think everyone would agree, has fallen far short of what everyone wants in terms of technology in healthcare. So how do we avoid that pitfall of the EHR when it comes to virtual care? Genevieve, maybe you can address that.
I think it's a great question. So a couple things. I was just going to comment briefly on the idea of an e-visit. I think that to Rita's point, that idea of what's most appropriate at that particular touch point and that's effective is really that key concept. And in many cases, an e-visit for something that's extremely protocolized, that is limited in scope and can be done in that manner, can be absolutely appropriate and can bring an amazing experience to that patient and consumer. I think that the key is really that idea of experience design and understanding workflow and how those pieces have to be woven together. And that was, I think, in many ways what was missed in the creation of the EHR and where we are today. It was simply taking what was in that paper chart and putting it into a system of record without really an understanding of the design and the way that entering that data, all those parts of the interaction could optimally work. And we're still suffering from that today. There's clearly innovation around that to make that better, but that is the key. So taking this now to virtual care, I think it is going to be some of those pieces that we still deal with within the in-person setting that we have with the EHR, such as data entry, such as integration of the information that a provider gets when they do a virtual care visit. Currently, many of the platforms are not fully integrated. We also have the example currently, like with our remote patient monitoring platform, where parts come together, but it's not fully this integrated experience for the care team. So we're still working through a lot of these pains.
So I'm going to put you on the spot a little bit and try to paint a picture of the frustration that average people like myself feel when you're trying to consume healthcare, for lack of a better term. So I've been having some problems with my right foot recently, and so I had to do ultrasounds and x-rays and MRIs to finally figure out what was wrong. So before the MRI appointment, which was given to me that same day, I was told that I need a pre-authorization, and that as soon as the authorization information would come, then the appointment would be confirmed. Otherwise I would have to sign something that shows that I waive my, not rights, but basically I would have to pay if the MRI authorization didn't come through. So helter-skelter panicked. I called the insurance company, and the insurance company said that we don't know exactly. Can you call us back a little bit later? Then I called the provider again, and the provider was like, we've sent in your paperwork, you can now call back. So then I called the insurance company again, and they said, for your insurance, you really don't need any kind of pre-authorization, you can show up. So this level of miscommunication between providers and payers and what is on your plan is not something that the provider world has really paid attention to. So is that something, but as a consumer, I'm seeing a real disconnect, and that's something that's really creating a problem for me. So who should solve this sort of a technological and, lost in translation sort of problem? Is it more on the insurance side? Is it more on the providers who are setting up the appointment to know what is actually correct?
I can take a stab at it, and Rita, I'm sure you'll have some comments on top of it. But, I think that we are at such an interesting time where it is clear that healthcare is going to become and has to become much, much, much more consumer-centric. I think that, and it's clear historically that these difficulties, the red tape has been to the advantage of many ways, both payers and providers in a variety of ways, right? Even though it's extremely inefficient. But I think, the amount of money that a consumer spends and also the experience that they have, they're demanding something very different. So from a regulatory perspective, that is going to be one way that all of this is going to be pushed forward. I mean, even, what's about to come upon us with 21st century cures and the availability of rates, there is going to be much more transparency, and that is going to, I think, solve certain things. Certainly, we can have comments about, multiple payers, single payers, different models of care, and how that should look, and how much is healthcare a right versus something else. But certainly, it definitely will change. Your experience, unfortunately, is probably a pretty common one. And, at the front line of a payer, I know why you got of a provider, I know why you got that notice, but it didn't apply to your particular plan. So.
Right. Rita, I don't know whether you want to take that hot potato of single payer, not single payer, and what the future holds, but if you would like to go right on ahead.
That's a tough one, but I wanted to just quickly go back to your previous question. There is an absolute responsibility, I think, for all members of the value chain for healthcare to move in the direction of consumer transparency and empowerment. And that means we all have to do a little lifting, and the requirements around interoperability, I think, will help enable that. But when I was on the payer side, I know that it was something that we really wanted to alleviate, in particular about your example, is how do we make that easier? And then on the provider side, how might we, through technology, share data and information and do these validations real time and not put the onus on the patient to have to worry about these? And certainly at Mayo Clinic, when we're dealing with serious and complex conditions, that additional burden is pretty significant for people to have to navigate when they're dealing with their health. And so when I say simple, seamless, cohesive, integrated experience, that's what I'm talking about, right? We have to solve some of these bigger problems, not just within the four walls of Mayo.
So let me switch gears a little bit and talk and ask you a few questions about how each of you are working with startups. One of the things we've heard recently through our reporting is that hospitals and health systems have frozen all activity that's not COVID when it comes to working with startups. So I'm wondering within each of your hospitals, and Genevieve, you can go first. What is the priority right now in terms of working with startups? What areas are you specifically, and I mean, is it AI to improve in back office? Is it AI to improve patient experience? And specifically what's within patient experience? So specific examples of where you're working with startups to attack certain big problems.
Mm-hmm. So I think it is important to acknowledge that providers as a whole have had financial challenges with COVID, and it really has, I think for us, made us want to be as clear as possible as, we partner with any vendor or even any project that we undertake as a system, really the goals of the project, the value of the initiative. And I think at the end of the day, we've really come to this idea of sort of a balanced program portfolio with the idea that we need to make investment. We have to make investment to get to the future. And there are going to be pieces where, we may want to build it ourselves, but in many cases, partnering is a much smarter way to get there. And so I did mention a few of the capabilities where we've done some investment, but certainly the idea of a personal digital assistant. We have currently a partnership with Suki where we are working on that quite affirmatively and trying to bring sort of a different experience to providers at the front line in how they interact with technology. I mentioned as well our Systems Operations Center and that idea of real-time awareness and bringing that even to the front line. So all the way to a system perspective, all the way to frontline teams and doing care progression huddles and really what's the next best action and really bringing AI recipes into care. And I would say, as a whole, we are partnering in a variety of ways, both on the idea of sort of our app ecosystem, both in terms of how we interact with patients as well as how we interact with providers. We think that that's going to be an important area where partnering in many cases will be important. And then AI, I would say as a whole, is an area where we do have a variety of partners and are always open depending upon, that fit with approaching partnerships. So I think it also depends on the type of arrangement, whether we're talking about certainly, being a test bed versus just an implementation partner, an investment, whether we're procuring, there's a whole variety, whether it's technology alone, services that go with it. So certainly we have a whole range in that portfolio. And we think that having that balanced portfolio makes a difference because not all are going to end up being as successful as we would like, but quite a few will be. And we think that having that view is quite helpful.
I'll stay with you, Genevieve. I was really interested in the slide where you talk about the deep learning algorithm that you've developed. Mm-hmm. Is that in partnership with an organization? Because you said you were trying to make it available on the app as well.
Yep. So in this case, we did a combination of partnership with the University of Minnesota, so Department of Computer Science and the Institute for Health Informatics. So with the university, and then we partnered with Epic, and they, because it was COVID related, they did quite a bit of development as far as consuming imaging. So they gained additional capabilities in that process. We also tested their cognitive computing platform, and now we're making that available through what they call their third-party app orchard. So it's the first time they've shared a machine learning algorithm nationally. So it's a neat solution. We're excited about that.
And has it already launched or will be?
It did. It just launched.
Okay, great.
Just launched.
Thank you so much. So Rita, to you now. Can you talk again a little bit more about what areas you're working with startups? What is front and center right now compared with what it was maybe 6 months ago when you joined, or 7 months ago?
Yeah, so a year ago is when we launched our 2030 strategy on Cure, Connect, and Transform. And that's when we knew, the organization knew that they wanted to bring in a chief digital officer. We're even bringing in a chief data and analytics officer. We launched the platform business and really doubled down on driving future growth. And of course, during COVID, it was all hands on deck across all areas of the organization, including Mayo Clinic Ventures, as well as business development. As we've stabilized in terms of our approach and reactivating the practice, we're turning our focus, at least in the areas of digital and the platform, back to accelerating because COVID has proven that we have to accelerate. It's also exposed gaps in terms of what we want to deliver. So I would say specific areas that we're looking at, and this is primarily for the platform business, is around data and analytics, artificial intelligence, obviously really important, and we're partnering with Inference with that partnership. We're also looking at what's the virtual care platform, not just our solution for Mayo, but for our platform business. How do we pull together our virtual care platform with remote patient monitoring, hospital at home type solutions, and what are those partners that we want to work with to solve that whole infrastructure to drive that program. And then of course, remote diagnostics is another important area for the platform that we're looking for appropriate partners to help fill out our solutions. And these are all emerging platforms for Mayo Clinic.
Perfect. I will continue asking questions, but in the meantime, I wanted to open up the chat for questions from the audience. So the audience, feel free to add questions to the chat, either specifically directed at either Rita or Genevieve or more broadly, and then I will field them directly to them. So while the questions are coming through, I wanted to talk a little bit about the hospital of the future. How do you sort of create a patient-centric healthcare system in the hospital when physical distancing and the pandemic is on top of mind of everyone? Genevieve, you can take that.
All right. It's a challenge, and I'm just going to say that up front, and it's a challenge on, I would say, a couple of levels. Outside of thinking about truly the hospital of the future, social distancing as a whole, does take something away from the overall experience. So whether we're talking about a patient that is COVID positive and the person that is providing care on the team is in full garb PPE, and you can't even tell what they look like, that interaction, probably doesn't feel very patient-centric. And that's like the most extreme. But even then, talking to somebody with a mask on, how do you engage them and have that conversation, that eye contact? How do they know what you're really expressing? How do you know what they're expressing? So we've been trying to train our staff in really thinking about that carefully. So if you're expressing emotions, expressing happiness for something they've told you, or that you're concerned about something that they tell you, verbalizing that, and also perhaps speaking louder, and just having that in mind. The other thing I'll just mention up front is that, our physical plant wasn't meant for social distancing. I mean, we could see that in our emergency rooms. We could see that when we did have some overflow, significant challenges. We do have some hospitals that do not have private rooms. So, what do you do there? And we have to keep everybody safe. So I think, just speaking to that up front. Now, the hospital of the future is a smart hospital. I truly believe that. And it does mean that, in addition, I mentioned plant, it does mean a significant investment in the overall infrastructure, and being sure that even, our basics around our network, our wireless, et cetera, are able to accommodate that. But certainly there's great examples out there of, if you go to Japan, there are examples of truly like modern hospitals that are patient-centric around all the parts of what they would expect and be very convenient, even down to, light dimming and all the comforts that you would want at home even.
Rita, do you want to add to that, or should we go to a question from the audience?
Yeah, I actually think that the hospital of the future is very much being informed of what we're experiencing now. I think we're starting to be able to separate what are those necessities that we need in-person care for, and how can we deliver the appropriate care at home, or on the go, right? And where it's necessary. And I think we should take a step back, and we should rethink and reinvent the whole system. We talked a lot about these components. It's not necessarily consumer friendly. How do you support distancing with your family? How do you make it safe for your employees? I think all of these things we need to rethink and build it into the hospital of the future. I think technology is just one component of it, but I think understanding what's the true important touch points are going to be the work that we need to do. It's going to change how we do our workflows. I'm really hopeful that as we reinvent this new structure, we do spend some time on joy and how do we make that situation better. So I think there's a lot of opportunity to take a step back and really, really think about not just interesting technology that can be applied. I know we talk about Bluetooth and navigation, and these are all really important things. But I think care delivery itself will change significantly over the next 10 years.
So I have a question from the audience. We're actually tackling that issue more deeply tomorrow, but it's a very good question for Rita and Genevieve as well. So we'll start with Genevieve. The question is that mental health disparity is high, though it has been shown that it increases the physical health expenditures by 3 times. What perspectives do you have as providers to move the needle in this area now that there are metrics proving this?
Yeah, I think that this is a true societal challenge that we have, and it really is in many ways one of our wicked problems that we do need to solve. And I don't think that we have the full solution in mind. We do know that if we can provide services for behavioral health, mental health, and addiction on a very continuous basis, that in many cases we can avoid some of the costs that are associated with mental health morbidity, as well as secondary diseases that somebody with mental health may have. But that is, I think, historically been a significant challenge, whether we're talking about from a payer lens, and also there is a shortage today, in the state of Minnesota, more broadly in the country, of services around mental health. Certainly there are some very interesting innovative solutions around engaging people with mental health conditions in a much more affirmative way, even digitally, but that may not be fitting for every person that has a condition. But certainly, I do think we're going to see something different. We're starting to innovate around this quite a bit. We know that it's going to be extremely important. The other part I'll say, and this is now wearing my hat on the healthcare system, population health, value-based care side of things, is that there is a lot of willingness on the part of payers to innovate around this and to partner on this and to try to bring services in a different way, because the cost is real. And also outside of the cost this year, the morbidity that perhaps a patient that has mental illness and is not able to manage other disease or their mental health disease, just adds on to it. So there's definitely opportunity there.
Rita, do you want to take that on as well?
Yeah, I really agree with everything that's said, but I will add that this is an area where I think technology can make a huge difference. This is a space where people feel quite alone. And when you think about the extension of monitoring and what monitoring could do, not just outreach with virtual visit or asynchronous sort of visits in this space, but how might we create monitoring tools and programs to be more proactive and making those connections and helping alleviate some of the stress and strain, especially after care has been provided and ongoing care. And I think this is an area where I hope a lot of innovation can spring from.
It's interesting you
and
mentioned.
If you don't mind, if I could add on to that, I think that talking to some of the behavioral health providers, mental health and addiction providers, there is a significant belief that the way we do diagnostics and monitor mental health conditions is going to change very significantly. There will be sort of these instruments that will be almost like laboratory diagnostic tools. And there are some examples and prototypes of them. They're not as widely used yet, but I think that will be part of our future as well.
Sorry for interrupting you, Genevieve, when you were trying to speak. It's recently I had a conversation with a physician executive, and he painted a rather dark picture in the sense that the mental health and the loneliness epidemic that we're seeing in the US is results of decades of erosion of American culture. And he doesn't know whether healthcare alone will be able to solve the problem and whether tech is the answer. So although I'm asking you questions about how you are tackling mental health, it really stayed with me that the problem is much larger than any one industry, I think, can solve. And with that editorializing, I'll go over to the next question. That comes from Angela, and she's talking about what's the best way for a startup to connect with both Mayo and Fairview to see whether their solutions are sort of a good fit for the strategies you have. How do you accept inbound queries, and how do they do so? Rita?
Yep, I can start. So you can reach out to Mayo. So go to mayoclinic.org. And you can search for Mayo Clinic Business Development and submit your query that way.
And it's not going to go into a black hole?
No, we have a lot of needs to solve for, and so we want to find those great fits to help solve our problems.
Perfect. Genevieve, go ahead.
We also have a ventures arm, but at times that's not actually the right way for it to come in. So I think if you reach out to me, that's probably the simplest thing in this case, but I love the idea of having a single place to vet all of that. It's something we probably need to do, Rita.
So let's talk a little bit about the financial challenges that hospitals are facing, even if it may not apply directly to your particular hospital. I mean, I think it goes without saying that because of the COVID-19 pandemic hitting us so hard, elective procedures and all of that has reduced, and you, Genevieve, talked about backlog of procedures. So how is your organization dealing with this lack of revenue? I mean, there was some federal help, I understand, but how are you looking at it, and can startups help in that regard?
I can try first. So, as a whole, I think that that having financial challenges as a result of being clearly very volume driven in how a provider of healthcare is able to be sustained, this came out loud and clear. But it also helped us to see perhaps places where we don't have quite the efficiency, or perhaps could deliver things in a different way. You know, all of this made us realize we could emerge as a different organization. We have taken a hard look at our finances. You know, in our health system, we actually did have to furlough folks, and we've had to deal with some difficult financial challenges. I think as a whole, we are really trying to keep those principles of having a balanced portfolio in mind. Meaning, again, we need to do the things we absolutely need to do. We need to continue to improve in just measurable, like what you would do day-to-day ways, but as well, we need to be able to jump. So we do try to continue to invest in ways that we can improve and innovate. You know, I would say that for startups, really, when we start, we want to understand the value of what a solution is going to bring. That is, you know, and it may not be this immediate thing. It may be something that's going to pay off years later. We have multiple examples of solutions that we brought into our healthcare system that we knew the payoff was going to take some time, but we really do, I think, believe that that's going to be a really important piece as we talk about where we invest and how.
Rita, you're probably in a slightly different position when it comes to financial challenges, but how do you?
Yeah. At the onset of COVID-19, we were really quick to respond to reduce cost, and like many others, looked at things like reduced hours and furlough, and really focused our employees on direct care and supporting that direct care. Like many people, I'm working from home right now to make sure that our hospitals are safe. So that was something that we focused on. Equally important, we're looking at how do you create sustainable solutions and driving more efficiency. On one side, we're changing the consumer experience to make that more seamless and more customer focused. But there's a hard look internally to say, what can we do to drive more effectiveness, efficiency, speed to these solutions? And so I've been spending a lot of my time in my current role equally focused on how can we leverage AI to help drive efficiency? What can we do to streamline how we build products and services that are much more effective? How do we introduce more value set of a program so that we can measure the effectiveness during that experience? And so I would say, yeah, there is a material change in how we're approaching digital within the organization.
Let's talk a little bit about healthcare equity. I mean, I think COVID-19 brought into sharp relief the disproportionate harm that was caused in communities of color. And then both of you are in the Twin Cities. I know, Rita, you're closer to Rochester, but the region has seen a lot of racial unrest as a result of the George Floyd incident. So how is all of that affecting how each of you look at healthcare equity? And are there any specific policies that your organizations are undertaking to sort of do what you can to reduce that gap? Genevieve,
as a whole, yeah. So as a whole, we have, I think probably the overall message is the idea of equity is a thread that probably weaves through both how we care for patients, how we think about patients, as well as how we think of each other and our compact to each other as fellow citizens. So it is truly not just a lens around patient care, but how we treat each other and how we think about unconscious bias as a whole. So just to acknowledge, it's a widespread sort of thinking mindset that needs to be part of how we conduct ourselves more broadly. So I think, for one, that has been a big message, I would say, within our organization, and really trying to just, have that at top of mind and not something buried. And then I think the other big part that we realized in thinking about health equity is that to get better and to measure and innovate around it, we need to be measuring the factors that maybe lead to some of the inequities or underlying factors. So we have one thing that we're very excited about is a program to really recollect, validate and verify social determinants of health, social risk factors throughout the organization, to do it in a culturally competent way. And that theme of cultural competency is something that we're really trying to layer in all parts of the organization.
Rita?
I think most organizations understand that if they want to provide the best care or services, that they need to reflect the community in which they serve. And Mayo Clinic is growing globally, and we, not just locally here in Minnesota, but as we become more global, there is a need to not just understand and deliver equity, but to create solutions that are culturally relevant for the solutions that we provide. It's been an interesting time. I'm actually in Minneapolis, not too far away from where George Floyd was murdered, and so this is incredibly close to me, and this is happening throughout the whole country. And then, of course, COVID-19, how it's impacting people of color, African Americans in particular. So very aware of the role that we as individuals and as a society and how healthcare can contribute to driving solutions in this space. As we're planning our 2021 plans, current plans and 2021 plans, what I'm seeing in Mayo Clinic that's been very different than experiences I've had at other organizations is a really direct conversation about race and equity. And that's been, eye-opening and refreshing for me, because if you can talk about it, you can start to really address and get really clear on your goals, align on measurement. What I'm seeing is goals and targets across various areas of the practice, research. In my space, I'm thinking about how I can leverage technology to improve access, how we change how we recruit, how we interview, just really a deep dive into how we think differently about ensuring that we have true inclusion, diversity, and equity in how we think and how we practice.
I think it's a question about, as Genevieve mentioned, about how you collect data as well. I mean, one of our reporters is writing a story on how the AI algorithms that are being developed from this data that we're gathering, that may be skewed incorrectly because the data wasn't correct. It wasn't broadly collected, and so there are some issues that may have happened even when the algorithm is developed, and those gaps might be worsened. So there's so many pieces. Not just uncomfortable conversations about race, but even the nitty-gritties of how you collect data is so important.
That's exactly right. And biased data, and making sure that your algorithms are being trained and being validated ongoing to making sure that you have diverse data, your clinical trials are representative. These are all really important things that have downstream impacts that have to be part of the solution. And you're right, it's not just about relationships, but I do think if there's awareness and if we address some of these baseline bias, when our scientists and practitioners are solving problems, they take a step back and they say, is my approach going to be equitable? What is the downstream effects of that? And this is a moment across our society where these are things that we haven't spoken about overtly, right? And so we have to have the direct conversation because it does impact many facets of how we deliver care.
I lived in Minnesota for over 5 years, so I can just imagine how difficult such conversations, especially for Minnesotans, can be. I'll take a question from the audience. This is a very, very specific question. So Rita, I'll start with you. It says, what are your thoughts about a product to monitor ingestion of tablets, capsules, or caplets for adherence, like an FDA-approved ID cap? I'm just thinking of Proteus Digital Health, and they raised a ton of money, but ultimately it didn't pan out in the once it launched as a product. So with that, I'll let you guys answer it. Rita?
Yeah, so adherence is obviously a challenge, and there's been attempts to solve that problem. If there are ways that we can make it easier for people to remember, we know PillPack is a solution to help people make it easier, but it is critical for us to focus in this area. And I think I'd like to see some solutions that we can integrate into our app to make it easier for people, to adhere, but also educate people on the impacts if they don't.
Genevieve.
So Proteus was immediately what came to mind because we did work with Proteus with our ventures quite a bit, and really still think it's actually a very good idea because it's quite important, and there are multiple applications. I don't know if it's a timing thing. I don't know if in some ways it ended up being a cost thing. But at the end of the day, the idea of knowing, how adherent my patient is to, I don't know, methadone use or various chemotherapeutic agents, or are they taking an antiemetic, and where are they symptomatically? There's lots of very interesting use cases. So I'm hopeful that it'll be an idea that will move forward, but unfortunately I know it hasn't so far.
I think, again, completely speculating here, I thought Proteus was a very impressive company too, and other than the cost that you mentioned, which was certainly an issue, I always thought it was ironic that the first product that they would bring to the marketplace is intended for people that are I think schizophrenic. I think My Abilify was the product. And if people are already a little bit anxious and worried about who's watching them or what's happening to them, for them to have something that constantly monitors them, it just didn't seem that would be the right product for something like that. That was just my take on it. But I don't know whether you felt the same way.
Yeah, I think that the first application, to your point, in making this something that becomes more ubiquitous was probably one of the downfalls. Yeah.
So we're closing. We're kind of nearing the top of the hour in terms of ending the conference, but I'll take one last question from the audience, from someone I know. He asks, isn't the real question around acceptance of digital health not one of technology, but rather the current payment structure, as well as our focus on treatment of illness, rather than the ability for detection, prevention, and monitoring that digital health promises? In other words, a pretty big infrastructure change in a fairly closed environment. Rita, you want to take that one?
So yeah, I'll venture to say that we have a cultural problem, not just a payer or a payment problem. We have a nutrition challenge. We have lots of cultural challenges and inactivity that we need to address. And then I think you're right. Absolutely need to focus on wellness, preventative measures, moving from a sick to a sort of healthy, proactive stance. Now, of course, Mayo Clinic is focused very focused on complex conditions, which is slightly different. But even through the tools that we have, a lot of our condition guides in education is really across the full spectrum of care to help people understand how they can be more proactive in these areas. We have over 1.3 billion users hitting mayoclinic.org with educational content on how to address their conditions.
Genevieve.
Yeah, I think if we did our job really well, better than could ever be expected, you know, my doing great work for, say, my diabetic patient is they never become diabetic, right? Or that we're able to actually have them be go from diabetic to no longer, right? So, and the payer thing, I do truly believe is going to be one of the true forcing functions around this, and that will help align things quite a bit. So I do agree with that to a large extent. I do also agree with Rita. The cultural part is a real component as well.
Great. Thank you so much to both of you for coming to the conference and taking time out of our really, really busy days to talk to us and share a little bit of our insight.